I hear you, and this is part of the whole initiative to end the epidemic. We need to tackle this from all ages and young, all groups, and particularly those of color. We have been looking at this, and I think part of this is education. A large component of things is education. We are also looking at the issue of ending the epidemic regarding those who are incarcerated, and that's another a group. We're looking at those who are over 64 years of age as the other end of the spectrum, because at one point we did not, we lifted the age limit because there was for testing, and we've allowed those over the age of 64 to cover for testing for them. We've looked at some of the issues of needle exchange, which is of note. We are now less than 3% of HIV is a result of needle exchange, whereas originally it was over 50%, so that has been a big change. The program, the governance initiative with the three-pronged approach, we are moving forward with that. The issues of pre-exposure prophylaxis, we have about 1,000 people that we've pulled into the program that way, and we have pulled about we've had 600 people who are not virally suppressed. We've been able to virally have them brought back into the program for viral suppression. So I think we're making great headway on this issue, but I do hear you that the youth are a group that we need to target, and not just, and the thing about, I find about children in general, or not even just children, but adolescents as well, is it's not just one area, it's the issues of other things we've spoken about. We've spoken about tobacco, we've spoken about synthetic cannabinoids, we've spoken about opioids. So I think this is something which is more of a comprehensive thing we have to tackle on both HIV/AIDS and hopefully be able to tackle it for those other areas as well, even hepatitis C that we've spoken about. So hopefully, as we move forward with our prevention agenda, we'll tackle all of that.
Thank you. Thank you.
Thank you, Senator. Oh, no, that's just finished. Assemblyman Rowe.
Thank you, Chairman. Just a couple questions, and there's some areas some colleagues asked questions about, but I just wanted to expand on them. One of them being limited service clinics as proposed in this budget. I know you mentioned earlier, targeting underserved areas and that type of thing. When these clinics, by whatever retail operation they're going to be, are approved, I know the budget language talks about how they'll be approved, and they have to demonstrate this commitment to the medically underserved areas. Will that be like a continuing evaluation? If, say, company X, who's a commercial pharmacy, comes and says we're going to open a dozen clinics, and then they go open them, and presumably they're going to see the same types of issues that maybe other medical providers might see. Some areas are maybe more profitable, others aren't, trying to strike that balance. And down the road they decide, they're going to close some of them that might be in some of those underserved areas. How do we ensure that continuing commitment? Well,
as we move forward with the retail clinics, the goal is to make sure that they are in these underserved areas, in order to, and also to encourage them to, as I mentioned before, to tie those who come into those clinics back to their primary care doctor, and to use the health information system to do that. If your concern is that they will be in those, that they will not be in those areas, or is your concern that they will be there and then they'll leave, or they'll close in those areas?
Well, I think the language here does, provide that avenue that they're going to have to show some type of commitment, and presumably, specifically, they're going to say we're going to open here, here, and here, which is great. But my concern, I guess, is making sure they stay serving those areas, and whether or not this model of allowing, the corporate ownership of these practices is the best way to further that, as opposed to how I know some of them have now opened, where they're essentially landlords for some doctor's practice.
Well, we will monitor. We will clearly monitor to be sure that they are either staying open there, and if they're not, then we'll make our efforts to either whatever possible penalties that we could put forth.
Okay, thank you. And one other area that was touched on before, long-term care. Just wondering, we're starting to hear from providers of those type of services. We're seeing this all over the medical field, but a patient comes in, can have whatever, 45 days of Medicare, I think it is, and then they would go on to Medicaid, and, the reimbursements and everything else being what they are, I guess that creates somewhat of a struggle for that facility to serve that patient. Is there anything being looked at in that regard to, find ways to ensure that these facilities can survive in this climate?
Right. So in terms of, particularly with regards to reimbursement rates, I mean, obviously we are always looking to make sure that reimbursement rates are sufficient. Most of these services now are provided through managed care. Managed care organizations have to be able to prove on a very regular basis, usually on a quarterly basis, that their network meets their network adequacy requirements. And if that means they have to pay above what our normal Medicaid fee-for-service rate is in order to maintain access in certain communities, they are required to do so. And we do know that the managed care organizations do pay above fee-for-service in a variety of different settings across the state. So we have a mechanism in place that basically helps ensure that the access is sufficient. That said, we are going through a period of transition in long-term care, both a transition to managed care, particularly upstate, which is now happening. It was accomplished already in the downstate region. We've also had in the downstate region, though, the implementation of wage parity, which has created some adjustments and some challenges. And then also, I think what you're also seeing is if you're thinking more about the nursing homes, we're going through a process of transition with them around the change from, in essence, cost-based reimbursement to acuity-based rates, which is a multi-year phase-in. But the good news is that we're basically, we've been negotiating for, I think, 4 years, the Universal Settlement Agreement, which is a way for us to free up dollars otherwise spent on litigation and appeals, and free those dollars up to provide enhanced reimbursement to the nursing homes in a more direct fashion that helps facilitate a quicker move to acuity-based pricing. We had a very inequitable system of finance for a long time, and we're moving in the right direction. So I think, lots of things going on in long-term care reimbursement, but I think that things will hopefully, particularly in the nursing home side with this settlement, start to calm down a bit here in the near future.
Thank you.
Thank you, Senator.
Thank you. Senator Kathy Marchione, please.
Thank you. I've noticed in the executive proposal that there are 300 new full-time employees associated with the phased-in takeover of the local administration of Medicaid. Can you tell me how you envision that takeover to occur, how long it will take to phase in, and are there dollar savings expected for local government?
So certainly. So we began back in either 2011, 2012, I think it was 2011, the state takeover of Medicaid administration. It was tied directly to the implementation of New York State of Health, the health insurance exchange. It was tied to that because that gave us the system capacity to do it. Prior to that, there had been some small sort of incremental steps, in particular taking over some renewal responsibilities from counties. But with the launch of the exchange back in October of 2013, with new coverage being available January 1st of 14, the move to state takeover was launched in a robust fashion. Dr. Zucker gave you the stats earlier. 2.7 million people have used the exchange. The vast majority of those people are on Medicaid. About getting to the point now for what's considered what's called the MAGI population, or its modified adjusted gross income portion of the population, which is the vast majority of people who are on the program. They have a simpler definition of income. These are people who don't receive long-term care services, so they don't have asset tests and things like that. But we're fast approaching. I think it's around 50% of that population is now with us at the central exchange. The remaining population will continue to migrate in the years to come. It's a 6-year phase-in, so this is not a small change in the state-local government relationship. And we do believe that at the end of the day, the overall system of Medicaid administration will be cheaper. To give you a sense, before we began the state takeover, the cost on an annual basis of just administering this program at the county level was about $1 billion a year. So we definitely think at the end of the day, this will be a more cost-effective system. We have some important steps to occur, particularly with some further system upgrades to allow us to take on additional populations. But we think at the end of the day, after the phase-in is complete, we'll have a more cost-effective way for administering the Medicaid program.
And do you have, and maybe you said it and I missed it, but do you have an understanding of when the full phase-in will take place? When will it end?
So I think we have probably, I'd say, there's some uncertainties, but I would say probably another 3.5, at the most 4 years before it's complete.
Okay. I also have a couple of questions relative to the breast and prostate cancer awareness campaign. The executive proposes a 5-year, $91 million statewide campaign to increase awareness and rates on breast cancer screening and prostate cancer. But only $5 million in appropriation authority is identified for this purpose in the executive budget. Which settlement funds will be used to provide additional funding for the campaign? And where can the funding be found in the executive budget?
So there was a settlement that was done prior to my time in government with that was an Ingenix settlement that's being involved with that HRI has managed on that.
And where in the budget?
Well, there's money from the legal settlement that we will be able to use those monies for the breast cancer.
Okay. And the proposal includes a multi-million-dollar media campaign. What actions will be taken to ensure that women ages 50 to 74 and other high-risk populations are targeted in this campaign? So
as we move forward with this campaign, we will target all groups, all age groups. I think that this is a new program, and we will work with all of our team to figure out the most effective way to reach all different age groups and also relatives and friends of those who need to be screened. There's also, as I mentioned, there's also issue of peer educators. There's also, as part of the program, which will help reach those who are harder to reach just from a straightforward campaign. And we also have those who will help facilitate this, so that if somebody comes into the system and they're not able to navigate through that, which is not that uncommon when you get into the healthcare system, particularly if you don't feel well, that will help them also to get them into the system as well. And then obviously in part of the campaign, if we have these mammography vans, we want to make sure that people are aware that they're there, and that's part of the campaign as well.
And what components of the plan are linked to prostate cancer awareness? Do you know that?
So we will reach out to also as part of the advertising campaign, or not real advertising, but a public awareness campaign, I should say, on this for prostate cancer awareness as we move forward on this. I will get back to you about exactly how much and how we'll divide up the money on that.
And just one other question, and we've been talking a lot about doctors and retaining them here in New York State, and I can tell you personally, 2 out of 3 of my doctors, when they know what you do, and they know I'm a senator, talk about health care when I go in to see them. 2 of them are counting the years before they can leave New York State. I think that speaks very poorly for us in New York State. What's the department doing to retain primary care physicians in New York?
Right, so there's different parts to this. We do have the Doctors Across New York program. That's part of it, but I think that this is a comprehensive, we have to take a comprehensive approach to this. To get primary care doctors into areas, we're looking at how do you bring them to different parts of the state, particularly areas upstate where they may not be as quick to go, just because it's an environment that they're not as familiar with if they were trained, let's say, downstate. But we are working with schools in order to get physicians, primary care physicians, into some of the areas, they have to be more familiar with the area. And if we can have them spend time, 2-3 months during residency or even prior to that, medical school, but definitely during a residency program, they start to be more familiar with the community, they may be more apt to stay. And all the studies have shown that when someone's there for a while and they start to develop a practice there, much more feel a part of the community, they will stay there. And I think that that's one part of this. I think there's also the whole issue of just how do we provide care? It's not just primary care doctors, but it's also nurse practitioners, it's also all the other members of the health system, which we need to target. And I think that that's something which we need to move forward on as well. And some parts of the state, it may be the nurse practitioner who you're going to see on a more regular basis. But I hear you that doctors do leave, and I hear it not just from the role from the place I sit today, but I hear it from my own colleagues who I worked with for many decades as well. So I recognize that.
Yeah, it's I think a very serious concern, and I can tell you that the doctors I'm speaking of are doctors who were brought up here, who've lived here their lives, and have had their practices here, and they're the ones who are telling me, 13 years and I'm gone. So they're spending their time that they need to, but thank you for making sure we continue to look at that, because I think it's very serious in New York State, maybe elsewhere, but definitely in our state.
I think it's a big issue. We will continue to work with you on that.
Thank you.
Thank you. Senator Assemblyman Cahill.
Thank you, Mr. Chairman, and Madam Chairman, thank you very much, Commissioner Dr. Zucker. I'm not going to ask my questions now in the interest of time, but I would like to ask you to commit to answering written questions in a timely fashion on a couple of different subjects. I'll tell you now what they are.
Sure.
We want to talk about health exchange funding. We want to talk about early intervention, some of the matters touched on by my colleague earlier. The impact on the healthcare community of some of the proposed changes to the excess medical malpractice insurance program, and a couple of more questions regarding the Medicaid retail clinics, and finally just some heads up or some up-to-date information on capital and program resources available to our community hospitals. If it would be okay, if you would just make a commitment to a timely response to those, I'm certain we can avoid delaying this hearing any longer today.
We will get you written responses to that expeditiously.
Terrific, thank you. And Mr. Chairman, I also would join my colleagues who expressed some disappointment at the failure of the Department of Financial Services to attend this hearing. I understand the superintendent was just nominated last week, and that may very well be difficult for that individual to feel adequately prepared to attend here today. But I would hope that at some future Ways and Means hearing between now and the end of this cycle, that the Department of Financial Services be requested one more time to attend. There are numerous questions that need to be asked of these individuals who are responsible for a departmental budget in excess of $350 million, and also the fiscally most important industries in the state of New York. So I thank you, and I give back the rest of my time.
Thank you, Senator.
Thank you very much. Next would be, Senator Montgomery has left, and so I would say Senator Liz Krueger.
Good afternoon, gentlemen. I'm going to try to be quick. I know you've had almost endless questions. So probably my big one is, there have been so many questions about different parts of DOH and Medicaid redesign and where we are and where we are trying to go. Is there the equivalent of a management report? In New York City, we call it the Mayor's Management Report. And basically, it determines, sort of through a list form almost, all the different projects or big projects any given agency is working on, expectations, and then where we actually land on an annual basis. Is there an equivalent? I mean, I know with Medicaid redesign, I gave up after the 400th proposal. I used to joke there was a team working on every one of them, and I know we didn't really get all of them through. There really were, thank you. You heard it here. So is there some kind of like master updating report that you both keep so that it would help us understand this has been more successful than we imagined. This hasn't been successful at all. This we're behind on. This we're stating. We're still waiting to get started. I'm curious whether there's something like that that you actually have you can make available to us.
So at least I answer in terms of, obviously the report that Senator Hannan referred to is our annual report for the Department of Health, and that provides a summary level of initiatives that cut across the entire agency. Within Medicaid redesign, we have our project management work papers that summarize the status of all of our projects, all of the ones that have yet to be fully implemented, and that's available on the website. So you can see, and we update those on a monthly basis, you can see the current status of every single one of the MRT initiatives, and this is the 6th phase of MRT. So there's each of the phases has its own work plan, and you can see where we are with each of those projects. And that's been an important tenet of Medicaid redesign from the beginning, was to be very transparent about I think one of the first things we heard, whether it was Assemblyman Gottfried or Senator Hannan when we started MRT, was that was a feeling about the health department, was that a budget would pass and initiatives would be included, and then the question is, well, how is the department doing and been implementing it? We were very sensitive to that and have tried to be very transparent in terms of how we're implementing. But I don't know.
And regarding other parts of the department, yes, we keep a close tab on this. We meet obviously regularly, and I keep a tab on all of the different major projects that are moving forward. The deputy commissioners also know the major items that we are tackling, and we are kept update, or I'm kept up to date on that regularly, probably every other week. And
that's also on a website?
On the website, we have the major programs we do have on the website, and any new changes in those programs, particularly the ones that are very active at this point in time, are put onto the website. If there are areas of some of those programs where there may be additional concerns, then we do usually put out a frequently asked questions on that topic, because I realize that otherwise we're going to have a lot of calls about that anyway. So I thought that's the most effective way of doing that.
And going back to the MRT, where it's online, because I haven't had a chance to take a look, and I will, does it actually break down, we expected we would save X amount of money by doing this. We expected we would have better health outcomes for this subpopulation, and actually does that level of evaluation of where we are?
So what we do is, particularly for the ones for which there was a fiscal implication, so that it requires, you can look at claims data, counter data. We have within Salient, which is the system that we use in your company, that's a data mining tool. We have established what are called bookmarks, that you can actually go into this tool and you can literally, and the data is refreshed every week, so you can actually go in and see how these initiatives are doing. So we report out, usually I think on a quarterly basis, how we're doing on each of the initiatives dating back to the beginning of MRT. We also provide the legislature with a detailed report of all of those initiatives and what the savings estimates are in an updated fashion. So we do, and we go back and look at those initiatives, even things that we implemented 4 years ago, to see how they're doing. It was relative to the question that was asked about how we're doing relative to the carve-in of the drug benefit, which is a good question because that's one of the bigger ones. So we do that. The document that is on the website at the moment is the project implementation plan. So it shows all of the key steps, milestones for each and every project. And what you can see is that it tracks the times and dates of each milestone being implemented. So you can go back and see how many times the schedule was adjusted or things were delayed. And so you can see full well when each of those steps was implemented, and gives you a flavor to the degree to which it was implemented on time.
Thank you. We are, particularly when it comes to insurance and Medicaid, and I think any number of other issues in health, we simply can function or not function based on what the federal government does for us or to us. If I were to say, what are the 3 most important things the federal government could do to help you with your mission, what would those 3 things be?
Well, one, always resources.
I was going to say, more money?
Money is always a good one. Collaboration on some of the projects that we are moving forward on would be helpful. And we do get that, at least on some of the public health issues with CDC. So those are two big ones. To hear our concerns about specific areas or when we reach out to the federal government on particular areas, sometimes we don't hear back from them as frequently as we would like to.
We have a number of outstanding waivers we're still waiting to hear from them on. Any expectation of hearing something?
Sure. So we have a lot of irons in the fire with the federal government at any given time with regards to the New York Medicaid program. I bet right now somewhere probably have between state plan amendments and waiver amendments, probably somewhere in the range of 120, 130 requests pending with the federal government. I think one of the challenges we have is dealing with the CMS system and their ability from a resource standpoint to sort of keep up with the rate of change. One of the more challenging things has been for our Medicaid managed care plans. The federal government made a decision about a year and a half ago to begin sending all of our Medicaid managed care rate updates, rate packages, through their Office of the Actuary, an office that was built simply to assist the Medicare program, never for the roughly 46, 47 states that operate Medicaid managed care plans, to also review all of our rate packages, of which we have multiple ones in any given year. And so that has been a challenge, trying to get that approved. But, you know, to a great extent, I mean, I think our relations with CMS relative to Medicaid are in a better position relative to the OPWDD challenges. That was low points in our relationship. But I think things have improved lately, and so they're trying hard. I think part of their problem is just a lack of resources, particularly resources with the right subject knowledge in some of these areas. So there still is a bunch of things that are still pending with the federal government, and I think it's just one of those things we just collectively struggle with on a day in, day out basis.
Thank you. Thank you.
Thank you.
Thank you, Senator.
I'm sorry.
Thank you, Senator. Go ahead.
Assemblyman Goodell.
Thank you. And thank you, Commissioner, and you as well for being here. The governor proposed a 15% cap on outside income for all legislators, even though there's currently state law that prohibits any outside employment that would conflict with our legislative duties. My question to you is three parts. First, what are you paid as the board president for Health Research, Inc.? What are you paid total in outside income? And do you believe there should be a 15% cap on all outside income for executive branch employees?
So on the HRI, that amount is, I have to take a look back, it's probably about 50 or 60,000 on that. And I sit on one board outside, and I can't answer your question on what I think, because I haven't looked at the data close enough on that.
We've been asked from time to time to pass legislation on minimum staffing levels for nurses and nursing homes and hospitals, and we're told that the staffing ratios are too low now. Do you believe that the staffing ratios for nurses are too low, and is there any funding in this budget to increase funding for nursing homes or hospitals to address that?
So I think the question about nursing in general, there's two parts. There's nursing homes and there's nurses in hospitals in general and staffing ratios. I think the issue of staffing ratios, is the bigger issue is really, in general, how do we provide care to patients who are in the hospitals. Not all care necessarily will require the level of skill of a nurse, and that's why we've been looking at other those who can assist nurses as well. I think this is a challenge that we have been faced for a period of time. I think that we are moving forward with looking at also in nursing homes in general, what kind of aids. And then there's also the issue of home care and nurses. So we have been looking at how can we get aides who work in homes to provide some of the services that nurses were doing, including injections or medicines that would probably keep that person at home rather than have them have to go into a nursing home or into some kind of other assisted care facility. So I think that this issue of nurses in general is a little bit more of a little more complex than we would mention.
And I take it there's no specific funding allocation in this budget to address any of those issues?
Well, we did, I can't comment specifically on the nursing ratio, but I could look back into that. But, the budget addresses a lot of these issues just in general in providing care, not just, I don't think we should just target the one part for nurses because there's so much else involved in the health delivery system in general. So.
I had a few questions on the health exchange. When the legislature first approved this, we were told a couple of things. One was that it would be self-sufficient, and secondly, that it was necessary in order to qualify for federal financial support. Of course, the second characteristic of the federal financial support, the Supreme Court said it didn't matter whether you had a state exchange or a federal exchange. This budget, as I understand it, includes $58.7 million specifically for the exchange, an additional $229 million, I think, that relates to the Medicaid portion. And I believe you said the overall cost of the exchange right now, including the Medicaid side, is in the range of $575 million. Mm-hmm. My question is, if we eliminate the state exchange and let the federal government pick it up, would we be saving in the range of $500 million, or would we still be incurring a significant portion of those costs?